change a little bit of course today. And, there's been some phenomenal talks and some pretty heavy talks today. Yesterday, we talked a little bit about testosterone therapy and prostate cancer. And in my opinion, that was a pretty easy topic. I feel like our research is sort of alone in that category. But this is a much bigger topic. And the truth is, I can't do the topic of cardiovascular disease and risk associated with testosterone. I don't know that I can do it complete justice in 20 minutes. So I'm going to ask the critique panel. Maybe we can engage more. And I'm hoping you'll all come back for the critique panel. We can get into this topic even more. But what I am going to do today, I'm nothing if not a pragmatist. And what I'm going to try to do is really distill down what I think what you need to know as a urologist or somebody practicing in this realm, some of the key studies and some of the things that I really think you need to be in a position to tell your patients. My disclosures have not changed. We've come to know this guy over the last day or two. This is our patient, our key patient, 66-year-old, who presents to us as a potential candidate for testosterone therapy. Again, I've tried to, this is not, as Jesse would say, this may be a little mamby-pamby, but I'm going to look that up later on, Jesse. But my goal isn't to trick anyone. This is a guy who we should be thinking about testosterone therapy in. And so I don't want to be tricky with you. And at the end, we're going to come back and we're going to talk about, would we treat him with testosterone? And the question we're going to pose today and what we're going to answer by the end of this talk is, if we put him on testosterone, do we have to watch our back? Do we have to be telling him about his risk of cardiovascular disease? Does he need to get clearance from his cardiologist? What do we have to do to protect the patient, first and foremost, and to protect ourselves? And this is a story that really began with an Institute of Medicine review of rising testosterone prescriptions and concern that we weren't doing the right thing as a population of doctors, that perhaps pharma was leading us around by our noses. And of course, the AUA, aligned us with this. And this was the same statement I shared with you yesterday. So what I want to walk you through relatively rapidly today are the things that I think you need to be able to quote about the benefits of testosterone therapy and in making those decisions for your patients. What is the evidence that T treatment may be truly harmful? And then I think you need to know something about studies that have shown that absence of risk. So what about the studies of benefits? Well, I think this is the study that we all need to know. This is the Schneider paper from 2016. And this is essentially 3 parallel randomized controlled trials. So this is the gold standard. Patients recruited with symptoms, patients with unambiguously low T, and treated up to a therapeutic level between 500 and 900, monitored. And these 3 parallel randomized controlled trials looked at 3 domains: sexual function, physical function, and vitality. We can get into the details of this study during the critique panel, but I think this is the study that we should be quoting when we're acknowledging the benefits of testosterone replacement therapy in hypogonadal or testosterone deficient men. It certainly improves their sexual activity and quality of life, potentially erectile function, physical performance, their mood, and they have a lower severity of depression. So these are important things. What about evidence for harm? Now, really, our world was turned on end with the TOM trial. So I'm taking you back to 2010. This is when the alarm bells went off. This is when we all became worried. You may recall this as a randomized controlled trial looking for benefit in aging, more frail men, seeing if we could activate them, reduce their risk. And this trial was stopped early and led to this publication suggesting that there was a disproportionate number of adverse events occurring in men who were treated with testosterone. This is where we then saw a cadre of additional studies using more retrospective data to try to provide clarity. And the thing that I like to say about the TOM trial is that this was a trial of efficacy, not of safety, so it really wasn't designed to adjudicate some of these adverse events that were reported, and there really wasn't a lot of resolution or clarity on what these adverse events were. Primarily, the most common adverse event was just peripheral edema. So out of this came studies that captured a lot of attention. And I heard some of the critique panel mention these studies. Some of you may have mentioned these studies. Some of these studies were presented at the AUA at the time. There was the vegan study, which came out of the VA, which noted a disproportionately high increased risk of mortality, MI, and stroke. There was the Finkel study published in PLOS One, suggesting that there was a significantly increased risk of MI after being treated with T. And then there was the Bradley-Layton study, which also suggested a disproportionate number of cardiovascular events. And what I would say about these studies, while they were published in relatively premier journals, while they captured a lot of interest, I think they really had some fundamental flaws that we then went out to try and correct with subsequent studies, and that the NIH was really keen to acknowledge these flaws and to get some better modeling of data about adverse events. But before I do that, let's talk about some data that I think you need to understand about absence of risk. And there's many more of these studies that I can't share with you today, but so this is the TEAM trial. So this is the idea of let's look at really objective hard markers of outcome, coronary artery intimal thickness and calcium scores. And this is a randomized trial of men who were 60 years or older, treated with T up to therapeutic levels, and then monitored for cardiac changes in an objective way. And again, there was really no change over the period of this study. So giving us some sense of security that we're not seeing these objective measures changing among the treatment group. And this study this is a Kaiser population. This is I call it a sister study to ours. This was one of these other groups that was funded by the National Institute of Aging out of Kaiser, looking at a contained, controlled population, all within a closed healthcare network. And again, suggesting not only did we not see increased risk of cardiovascular events, but maybe we're even seeing evidence of a protective effect. And this is just my distillation of that study. So a little bit smaller than what we were eventually capable of doing in the VA, but again, finding some reason to give us calm about this tendency towards cardiovascular events. So skip through this. So let me get back to the study we talked about yesterday. When we set out to study men in the VA, we really set out to do two parallel studies because we certainly have to think about prostate cancer, this insidious, slow-growing disease, as different than cardiovascular disease. Prostate cancer is a disease that is this cumulative exposure potentially over time, whereas we really want to think about the effects of testosterone cardiac physiology and vascular physiology as when you're on the drug or when you first start the drug. So I do want to clarify that we're really talking about different studies here. For this, we hypothesized that men on exogenous T may be at increased risk for cardiovascular events, and our outcome measure was a composite risk, which is myocardial infarction, stroke, and thrombosis. And then we individually looked at those events. But our primary outcome, number one outcome, is composite events. We felt this was a really good place to pose questions of safety. Again, huge population of men. We capture all their data through a ubiquitous EMR. We, again, capture all this national prescribing data. And as I showed you yesterday, testosterone treatment is common. And if they have their myocardial infarction outside the VA system, we capture that through Medicare. Sorry for the theatrical slide transitions here. I thought I removed these. So our cohort here is these men aged 40 to 89. They enter when they first have a low T, similar to those who were evaluated for prostate cancer. They have to show that they're connected to the system. And exclusion criteria here are a little different. We have to address their active cardiovascular profile. So what you'll see is that when we assemble the cohort and we follow them through time, they're going to be a little bit different. And this is our primary composite outcome. Again, MI, ischemic stroke, and DVT. And then secondary outcomes are those events individually. I want to introduce the concept of new users. So what we really want to do in something that is not a randomized controlled trial is we want to do everything we can to eliminate the bias from non-randomization. So the best comparison we can potentially make is to compare those who are active users of testosterone, new users of testosterone, to those who may have been a former user. So there's somebody out there who a doctor felt was a candidate for testosterone, but there are those who are actively on it and those who are not. And we really think that is our best mode of addressing non-randomization and extracting some of that bias that could be introduced. But can we ever get at this idea of the true differences between people who are prescribed and not prescribed testosterone? So I think I alluded to this just previously, but we really have to characterize and we have to have the right comparisons. So in this study, we're going to compare current to former users. These are the kind of conditions that we need to adjust for. So at baseline, we're going to adjust for all their demographic variables and whether or not they have prevalent cardiovascular disease or not. And then over time, we're going to continually readjust for those things, as well as hospitalization and ever-changing comorbidity. What is comorbidity? Well, it's these major things, okay? It's really all about the testosterone, right? We want to capture people when we think they are actually taking testosterone. And I just want to pause and say, this is a little bit different. We have to be a little bit more precise than talking about prostate cancer. Prostate cancer, again, this slow disease, we could talk about just ever and never exposure. But here we really need to do analyses that capture men when they're on the testosterone, because that's when we think they're at the highest risk of these events. It's when they're starting testosterone. And to do this, we really wanted to do sensitivity analyses so that we could account for potentially them having an overrun of their prescriptions. When did they really stop taking testosterone? And we built in another exploratory analysis of a case crossover design where we could have men serve as their own controls. So again, I told you this cohort's a little bit different. This is now 300,000 men screened in with low T, and after exclusions, we wind up with a little over 200,000 men. Their average age is about 61, and these are guys that have high prevalence of cardiovascular risk factors, hypertension, diabetes, obesity, and 40% have prevalent cardiovascular disease. The cohort changed, so the mix of how they're being treated with testosterone changed a little bit from our prostate cancer study. But again, there's 40% of them receiving intramuscular testosterone. We're always surprised, and I think this is true in the real world, and not something that's related to our outcomes, but the average treatment duration for men on testosterone is actually relatively short. And we could debate why that is, maybe in the critique panel. And this is just to show you the distribution of all the comorbidities, which was relatively similar across those who were never treated, those who initiated treatment newly, and then the former users. How did their testosterone change while on therapy? Well, this is just to show you their mean and median testosterone, serum testosterone levels. In this cohort, which is a little different, you can see that even with transdermal, they did show a little bit of an elevation in their T, but a much more profound elevation in their T with intramuscular. And then here's our results, which is to say that when we compare active current users of testosterone to former users, you'll notice that our measure of risk is awfully close to 1 and our confidence intervals cross 1, so there appears to be no increased risk of a composite cardiovascular event among men who are initiating testosterone therapy. Doesn't matter whether you put it on their skin or inject it into their muscle. That was the men without prevalent cardiovascular disease, and these are the men who do have prevalent cardiovascular disease. And again, what you'll appreciate is whether they have that comorbidity or not, their risk really does not seem to change. And in fact, similar to other studies, we see a slight protective effect. So my interpretation of our data is that the use of testosterone in new users of testosterone does not appear to increase the risk of a composite cardiovascular event. This is consistent regardless of mode of therapy, regardless of whether people have really significant active cardiovascular disease or not. Any study like this, even more so than our prostate cancer, I have to point out the limitations to you. And I'm running out of time, so I'm going to let you glance over these limitations, but really the key limitation is that we just can't account for residual confounding, okay? So let's fast forward and let's imagine we do the perfect study. So we've gotten as close to perfection now as possible, and some of you are familiar with the Traverse study. So the Traverse study was a randomized controlled trial. It's a 3-year follow-up study, multi-center, double-blind, of over 5,000 men, really trying to lay this question to rest. This is published about 3 years after our study, 2 years after our study. These are men who were screened in, symptoms, low T, and treated to a therapeutic level of 3 to 700, 350 to 750. Their events are MI, stroke, and whether or not they had a revasc procedure. They can do this because it's a randomized trial. And this is the publication you need to know. And so this is Linkoff, 2023, last summer. And I'm just going to read the final results for you, which is to say that in men with hypogonadism and pre-existing cardiovascular disease, testosterone replacement therapy was not inferior to placebo with respect to the incidence of major cardiovascular events. Let me restate that for you. Testosterone does not appear to increase the risk of cardiovascular events. So my final comment is to say that when we do retrospective large data studies and we do them right, and we're careful, I think we can get good results that will essentially give us the answers of some of these large, far more expensive randomized controlled trials. But I think our answer is pretty clear. So when we go back to our patient and we do our redux, this man with symptoms, with low T, we've talked about prostate cancer, we've talked about cardiovascular disease. My hope is that all of us will have some comfort in being able to treat him. And while I think it's fine for us to share what we think are risks, I do think that research to date has our back on these significant risk factors. So again, it takes an army to do this kind of work, and I look forward to answering more questions. I hope you all make it back for the critique panel. Okay. All right. Have a great day.